Welcome to part one of this presentation about the foot. So in this presentation we will review firstly the normal anatomy and remind ourselves about the location of normal accessory ossicles. We will devise a checklist for image review of the foot to make sure that you cover all aspects in making your diagnosis. We will look at a search strategy. We will look at the Ottawa rules for imaging referral, and then we will look at a series of cases that have fractures and dislocations for us to make some diagnoses. Remember, this is part one of 2 presentations. Here are some of the learning resources used in the creation of this presentation. This image shows the dorsiplantar, or the AP view of the foot. Take some time to look at the normal anatomy here and remind yourself of the individual components. You may wish to pause the video until you've completed that. This slide shows the location of accessory ossicles of the foot, which may or may not be present, and it's important that you do know where these are so that you don't confuse them with fractures and therefore make an incorrect diagnosis. On the next slide, we'll have a look from the lateral angle. Here we see potential locations of accessory ossicles of the foot from the lateral projection. Don't forget, some of these will also be visible on the oblique too.
We are familiar with the mortise joint in the ankle, but the foot also has a mortise joint which is at the base of the second metatarsal. The base of the second metatarsal is recessed between the medial cuneiform and the lateral cuneiform. We need to scrutinise this area very carefully because you can get a fracture dislocation to this region called the Lisfranc fracture dislocation. And sometimes it's only subtle changes in alignment that will alert us to this underlying injury. So when you're evaluating alignment, the medial cortex of the base of the second metatarsal is in alignment with the medial cortex of the intermediate cuneiform. Sometimes you might get a little angulation at the base of the second metatarsal, and this is normal, and we can already see an example of this here. But in essence, the second metatarsal is in alignment with that intermediate cuneiform. On the DP oblique view, the lateral border of the second metatarsal is in alignment with the lateral border of the intermediate cuneiform. In addition, the lateral border of the third metatarsal is in alignment with the lateral margin of the lateral cuneiform, and the medial cortex of the fourth metatarsal is in alignment with the medial cortex of the cuboid. Always make it a key point to evaluate these joint articulations on both the DP and DP oblique views, as these injuries can be frequently overlooked. Okay, so what do we need to check for when we're evaluating foot radiographs? Well, on the DP view, you need to assess the metatarsal and phalangeal shafts for any undisplaced fractures. You need to look carefully, as already discussed, at the Lisfranc joint. Check carefully at the lateral margins of the cuboid and calcaneum, as you can frequently get small avulsion fractures here. On your DP oblique view, again, check your metatarsal shafts. Always look at your Lisfranc joint. Check the tarsal articulations and also check the anterior process of the calcaneum. It's on the DP oblique view that this is frequently the only view that you can see this injury. Most hospital protocols for the imaging of the foot is for DP or DP oblique. However, if there's any possibility of an injury to your tarsals, or to the base of your second metatarsal for your Lisfranc joint, you need to go on and do a lateral view. And that's because quite often you will get tiny avulsion fractures to the anterior surface of your tarsals, and this is only appreciated on your lateral view. So when you do a lateral image, check the base of your fifth metatarsal, check your tarsal bones, and check the anterior surface in particular for of the tarsals. It's important to carry out a search strategy when you evaluate images, because if you don't, the chances are you'll overlook something. So we use the AABCS as our search strategy to make sure we look at everything. So A stands for adequate. Is the area of interest included on the image? Do you need further views? So if the patient comes in and they've injured their tarsal bones, you will need to go and do that lateral view. A is alignment. Do the opposing bones articulate with each other, or has there been a dislocation or subluxation? B is for bones. Are there any breaks in the cortex? Is the trabecular pattern clearly demonstrated? C is for cartilage, otherwise known as joints. So what you're looking for is for loss of joint space or diastasis, which might indicate that you have a dislocation. Check your Lisfranc joint carefully. And S is for soft tissues. Sometimes a soft tissue swelling can be really helpful in alerting you to the presence of an underlying injury. The Ottawa rules of the foot help clinicians decide whether the patient needs to have imaging of the foot or whether they don't need it. Patients that have bone tenderness at the base of the fifth metatarsal or at the navicular, or if they have the inability to weight bear both immediately at the time of the injury or in the emergency department, which is 4 steps, then those patients will need to have X-ray imaging of their foot. I think this is a great X-ray at showing how challenging foot X-rays can be. There's an awful lot of overlapping structures. In particular in this patient, there's a lot of overlapping soft tissue. And these soft tissue overlaps can quite easily create some confusion, because what happens is that when you have 2 overlapping structures of different densities, you get an optical illusion at where they meet in the appearance of an apparent lucent line. This is called a Mach effect. The best example of this on this picture is perhaps the lucent line that's running through transversely through the proximal phalanx of the second toe and then extends out into the soft tissues. And that lucent line can be mistaken for a fracture. So what you need to be aware of is that if a lucent line extends out into the soft tissues, the chances are that it is a Mach effect, and you can exclude it from being a fracture. There is actually a fracture in this image. Did you spot it before? We can see how there is a lucent oblique line running through the head of the proximal phalanx. It doesn't extend out into the cortex, but even so, this disruption, this lucency running through the trabeculae indicates that we have an undisplaced fracture. So what is it? It's a fracture where it's the proximal phalanx of the right great toe and how it's undisplaced. But importantly, you need to mention that it's intra-articular and it's involving the interphalangeal joint. Toe injuries are frequently common and they occur in both adults and paediatrics. And here we have a paediatric great toe. And we can see there is a tiny osseous fragment that is adjacent to the physis. And so therefore this tiny osseous fragment comes from the adjacent metaphysis. So this is in fact a Salter-Harris injury. Even though that osseous fragment is very small, it's still a Salter-Harris injury. So the most common Salter-Harris injury that we have is a Salter-Harris 2, and this is a fracture through the metaphysis that extends to the physis. So this is classically your Salter-Harris 2 injury. If you look carefully, it's really hard to, you can't actually appreciate it at all on your DP view, and hence the importance of always having at least 2 views. So what is it? It's a Salter-Harris 2 fracture, where it's the distal phalanx of the left great toe, and how it's undisplaced. We use the search strategy AABCS to ensure that we evaluate the entire image, and C stands for cartilage, otherwise known as joints. Let's look at the second and third metatarsal phalangeal joint. We can see that the joint spaces are clearly visible. There's uniformity to the joint space. Similarly, the interphalangeal joint and the proximal interphalangeal joints of the second and third toe are similar in that the joint spaces are visible, they're uniform, and so they're all very normal. The distal interphalangeal joint of the second and third toe are not well visualised, but that's because the toes are held in slight flexion, so you're not getting a true DP view of the DPIJs. But that's normal and mustn't be misconstrued as a significant injury. In comparison, however, if we look at the first metatarsophalangeal joint, we can see that there's no joint space at all. And more ominously, we can see that the base of the proximal phalanx overlaps the head of the first metatarsal. So this indicates that there's an abnormality here to the joint. And now the DP oblique view clearly demonstrates the dislocation of the first metatarsal phalangeal joint. Now this view can be slightly misleading, and it might give the impression that the right proximal phalanx of the right great toe has dislocated medially. But if it had dislocated medially, you would have been able to appreciate that medial dislocation on the DP view. So let's go on now and have a look at the lateral view. And now here on the lateral view, we can clearly see that the proximal phalanx of the right great toe has dislocated dorsally. Remember that the bottom of the foot is the plantar aspect, and here we can see that the proximal phalanx has displaced dorsally. Don't forget, when you look at dislocations, scrutinise carefully to see if there's been an associated fracture. Although sometimes, or in fact most of the time, the small fractures that occur with a dislocation are actually best appreciated on the post-reduction images. In this particular case, there are no associated fractures on these views. And remember when we saw the distal interphalangeal joint of the second and third toe, and we couldn't really appreciate them very well on the DP view, we can clearly see on the lateral view that there is normal articulation. So what is it? It's a dislocation where it's the first metatarsophalangeal joint and how it's a dorsal. Fractures to the base of the fifth metatarsal are incredibly common, and they're usually caused by an inversion injury. They're actually a form of avulsion fracture, as the peroneus brevis tendon inserts at the base of the fifth metatarsal. On this DP view, we can see two lucent lines at the base of the fifth metatarsal. It's important to not misconstrue this as a comminuted fracture. What you're looking at is a two-dimensional image of a three-dimensional structure. So actually, these two lucent lines are the fracture seen extending around the three-dimensional structure. And now on the DP oblique view, we can clearly see a break in the cortex. So this is an intra-articular fracture because we can see that the fracture line extends to the articular cortex. So this is an undisplaced intra-articular fracture of the base of the fifth metatarsal. So what is it? It's a fracture. Where? It's at the base of the fifth metatarsal. How? It's undisplaced and intra-articular. The base of fifth apophysis can be very confusing. Very quickly, the difference between an epiphysis and apophysis is that an epiphysis is seen in paediatrics and it is located at the end, at one end or both ends of a long bone or miniature long bone depending on the location. So for example, most phalanxes only have one epiphysis, whereas if you looked at, say, the tibia, you have two epiphyses, one at each end. And so an epiphysis is responsible for growth in lengthwise. Now apophysis is situated where tendons and ligaments insert, and this is responsible in growth in diameter as opposed to lengthwise. So how do we tell the difference between the base of fifth apophysis and a fracture at the base of the fifth metatarsal? Well, an apophysis lies parallel to the metatarsal. In contrast, a fracture is in a horizontal plane. And sometimes these apophyses appear displaced, such as certainly particularly the the fourth image from the right. We can see that this apophysis appears quite displaced. But remember, when we take an X-ray, it's a diverging ray, and that diverging ray can create the appearance of the apophysis being situated much more lateral to the adjacent host bone. Also to note is particularly the image on the far right, we can see that sometimes apophyses can actually be multifragmented. And this is normal appearance, and you mustn't misconstrue it as a multipartite fracture. Okay, so let's have a look at this image. We've got here an apophysis and a fracture. So our apophysis lies parallel to our metatarsal, and here we can quite clearly see a lucent line running horizontally, indicating that this is a fracture. So what is it? It's a fracture. Where? It's at the base of the fifth metatarsal. How? It's transverse, extending into the apophysis. Note, it doesn't actually communicate with the articular surface, so it's not an intra-articular fracture. A Jones fracture is very different from a base of fifth metatarsal fracture. Base of fifth metatarsal fractures tend to heal very quickly and without any sort of complication. Conversely, a Jones fracture tends to be much more complicated and frequently may occur with non-union or delayed union. So how can we tell the difference? Well, a Jones fracture is a transverse fracture that is distal to the styloid process of the fifth metatarsal. So essentially, it's distal to the metaphysis. And so therefore it's important to recognise this fracture and to describe it as such, so that it's very clear that you haven't misconstrued it from a base of fifth fracture. And here we have the DP oblique view of the Jones fracture, and we can quite clearly see the break in the cortex and the horizontal fracture line extending across the metatarsal. So what is it? It's a Jones fracture. Where? It's the proximal diaphysis of the fifth metatarsal. How? Undisplaced. We've now come to the end of part 1 of the foot presentation, and I look forward to catching up with you again for part 2.